Hi, everyone. We are going to move forward into the live case discussion portion of this session. Thank you for submitting your questions on the Q&A tab throughout the session, and please continue to do so through the cases and also into the question and answer part. We're going to move kind of seamlessly from cases to Q&A, and we will do our best to get to all of them. I'd like to introduce our panelists. So we have our recent excellent speakers, Sungmin Lee and Jorge Cortes, and Ellen Ritchie is rejoining us from the previous session. And we're going to be talking about some cases. Actually, Sungmin and Ellen gave me a couple of their cases, and we've sort of divided them up a little bit to try to hit some of the highlights of their talks, as well as some kind of controversial areas for discussion, which we think are going to be interesting to the audience. So we're going to start out with MDS. And in the first case, we're talking about a 74-year-old woman with low-grade MDS diagnosed back in 2013. The bone marrow biopsy initially showed fewer than 5% blasts, ring sideroblasts are 50%, normal cytogenetics, an ANC of 4.7, hemoglobin 8.9, platelets of 366,000, and she met criteria for low-risk disease by IPSS-R. So just with that information and with no further details, Sungmin, do you want to just talk for a minute about, so what do you do with just that patient's in your office, these are the numbers, what kind of questions are you going to ask to decide the rest of your management?
I mean, I think for low-risk MDS patients, still what's missing from this is also mutation data. So as part of initial workup, it's important to also note to send for mutation testing because there may be new therapeutic agents, or if you have an adverse mutation profile, that may warrant closer monitoring in these cases. For low-risk MDS patients, just like this, where they present with mild anemia, the needs are basically dependent on the hemoglobin and the red cells, and if they require transfusions or if they require fatigue. So it largely depends on their pace of their anemia and how fast it worsens, if they're symptomatic. For hemoglobin 8.9, it's very sort of borderline in terms of requiring treatment or not. So it's not absolutely crucial to initiate treatment considering considerations right away.
I think you bring up a really important point about the mutational profiling, and I certainly think for many years, actually, I think there was a lot of pushback on why bothering. What are we going to do with additional mutation analysis for this type of a patient? I think that, it was actually your ex-group, Jorge at MD Anderson, the MDS team led by Guillermo Garcia Manero has been saying for years already with different prognostic indicators that the low-risk patients can be really difficult to figure out. And you have some who are going to hang out for years and years and years and drive those long survivals with actually not much progression, and then others who progress really quickly. So we were clearly missing something. And maybe some of that is actually answered in the mutational data, which are now increasingly being incorporated. I think that's actually a problem with low-risk disease right now, that there are so many stratification systems, some with molecular data, some without molecular data, that I think clinicians don't really know what to do with that information. Jorge, I know you're more in the CML land right now, but I don't know if you have any comments on just adding mutational profiling into these low-risk MDS patients.
Yeah, I think you bring a good point. For a while, we didn't know what to do with these. Little by little, we're figuring it out. There's no question that there's still a lot of data that we get that doesn't really have a direct impact on what we do, and some that has only some prognostic implications. Now, the prognostic ones are relevant because it may make the difference between moving early.
Okay, the wonders of our new virtual world. So we had a little bit of a gap. Jorge, we lost you a little bit, but you had just launched into saying how mutational studies don't necessarily impact management right away, but now, at least for some of the patients, even if the management isn't directly impacted, prognostic implications could be gleaned sometimes from the molecular testing, and that's where we lost you. So I don't know if you want to round out that point.
Well, no, I think that it is important that we do the characterization again. It's not always directly applicable, but I think more and more we will learn more about it, and we do have to have it for all our patients.
Yeah, and I think if you look, for example, even at the SF3B1s, which we're going to talk about in a minute, there it looks like we are entering a land of different subsets prognostically that are actually going to be mutationally defined, A, and B, hopefully therapies are going to be relevant more specifically for different mutational subgroups. But I think here, the point of stopping this case at this point was, number one, just because a patient has a diagnosis of MDS doesn't necessarily mean that we're going to run right in for treatment. And I think Sang-Min made that point earlier that, maybe if she feels fine with a hemoglobin of 8.9 and she's doing her activities and everything is okay, you don't necessarily have to jump in. But the pace of things, I think, matters a lot. What's happening over time, what's happening to neutrophils, to platelets, is going to really define what you do next. So we actually did, on this patient, Dr. Lee got SF3B1 and TET2 mutations back. And the patient was initiated with therapy with darbepoetin, 500 mics every 2 weeks, with a hemoglobin of 9 to 10 maintained and actually not requiring transfusions. And then in July of 2020, I can tell you that, just to remind you, this patient was diagnosed in 2013. So there was a lot of hanging around time. In July of 2020, there was a drop in hemoglobin to 7.8. The ANC and platelets looked like they were still maintained. So then I'm asking next steps. So one of the things that I wanted to just ask people's commentary on is, what about the dosing? So is it once a week? Is it once every other week? Is it once every 3 weeks? Is it 500, 300? How do we figure this out? Ellen, I don't know if you want to comment on how you ramp up your patients on ESAs.
Generally, it depends on sort of the degree of the anemia and if they have renal failure. I mean, there are a lot of things that I'm going to factor into this. But generally, I start with 500 every 2 weeks and see if they have a response. And, I give it time to do its magic. And if patients have an outstanding response, sometimes I can drop to 300. But most of the time, I really start with that 500 dose and see where my patients end up.
So I think it's important to just get the reminder of the baseline EPO level, because I think that's
true. Yeah.
In here. And I think just to remind everybody that having a baseline EPO level and getting the EPO level a week after you start the ESA is not going to be helpful. So you want to get that baseline EPO level, because I do think it's going to help you decide. I think Ellen referred to, the time to do its magic is really important, right? Because patients get an injection and they want their hemoglobin to be 14 4 days later. And that usually doesn't happen. So you might actually have to give this therapy 8 to 12 weeks before you see much. However, if your baseline EPO level is 800, actually waiting that period of time, you may be waiting for something that is going to happen that isn't going to happen. And I do think there are plenty of patients referred in for consultation who have been on 30 weeks of ESA therapy without much of a benefit. So I think if you get the pre-test probability for response is going to be lower if you have a baseline very high EPO level, and if you have very high transfusion dependence, that's going to make you less convinced that waiting tons of time for the magic is going to be a good thing. But if you have somebody with a lower level and fewer transfusions, you want to make sure to give them enough time to actually respond. Would you guys agree with that, or any additional comments on the dosing or schedule or waiting period?
Sorry, go ahead, Jorge.
Go ahead. Well, I was going to say, I agree. It's just that the fact is that, when we didn't have any other options, you continue the ESA because, what else are you going to give them? Transfusions, of course, which you're already doing. There's the cost and other things. So even then it's not justified. But certainly now those dynamics have to change because you do have alternatives and you need to make sure that you offer them to your patient if they're appropriate.
Yeah, no, that was a nice softball, and we didn't even plan it that way. But the point is, yeah, so we didn't have, and I'm not talking about luspatercept, which we'll get to in a minute, but even when they were on week 30 of the ESA and not responding, I think what you were pointing to about, well, we didn't have alternatives, we kind of did. I don't think we love starting patients like this on hypomethylating agents. I think MDS, when you have, what else can we do? Do we really have to do this? And I think Sang-Min brought up very nicely in the talk that there are some data on the lower dosing and lower schedules coming out of MD Anderson in particular. And we actually participated in the randomized trial with you guys to try to show that maybe for some of these patients, if the ESA support isn't working, a lower intensity schedule of HMA might be a good way to go. In this particular patient, though, so we have an SF3B1 mutation, and we had from the previous slide that this patient actually had a ton of ring sideroblasts. So, So for the next steps, I think that was kind of pointing to luspatercept, which is our new choice on the block that you nicely reviewed in your talk, Sang-Min. I don't know if you want to make some comments about what you did for this patient.
So this patient did have the ring sideroblasts and the SF3B1, and it seems like from the neutrophils and platelets that patient still had low risk MDS, just not responding to the darbepoetin alpha. So I discussed luspatercept given the new data and approval. So the patient was amenable. We started luspatercept, and the starting dose for luspatercept is 1 milligram per kilogram. I started her on a standard dose, and actually after one cycle, her hemoglobin went up to 10 and remains at 10 or so. And I think what I didn't mention in the talk is that if you look at the luspatercept data, the transfusion improvement usually occurs within the first 1 or 2 cycles. It goes up fairly robustly. So there's different dosing for luspatercept, but I think initially you should start out at the lower dose because majority of people do respond to lower dosing.
Great. Well, that is a nice management plan for this patient who's been going since 2013 and doing pretty well. So that's a good outcome. I'm going to switch now to CML. So the second part of the session was on MPNs, obviously with a featured talk on CML. So this is one of Ellen's patients, a 35-year-old generally healthy man diagnosed with chronic phase CML in 2018. Started on imatinib and had a hematologic response pretty quickly after a month, but had side effects of facial swelling and nausea. And he decided to stop the drug after 4 months and was lost to follow-up. And before we even go on with the rest of the case, I actually stopped it here because I thought it was so important to talk about what happens with young patients who are responding to TKIs and they have some side effects and then they want to go off therapy. And Ellen has spoken at this meeting and others about, some of the side effect profiles of the different TKIs and what lead to treatment discontinuations due to side effects. Do you want to tell us a little bit about sort of what this patient and some of your other young patients with CML and why they're stopping?
I mean, the problem is they present feeling sick. We give them a drug, they feel pretty great after a month. And if they start having side effects to the medication, it becomes a really big deal for these younger patients. For him, the facial swelling in particular was one that he didn't, like to deal with because he thought it made him much less attractive. And instead of discussing this with his doctor or his doctor kind of discussing the fact that they were noting these side effects, he just gave up and stopped the drug and was lost to follow-up. I think it's really important when you start patients on TKIs to really talk to them not only about their response, but as to how they're feeling on the drug, because it's really important to try and keep these patients on. And younger patients, I think, are more vulnerable than others even. They're invincible when they start this. They feel like they're invincible. They're otherwise healthy. They're more likely, I think, to stop the drug. And he just stopped going to the doctor. He felt fine. He felt great.
So Jorge and I, over the years of talking about lots of different therapies for myeloid malignancies, right? There are all kinds of things, even on clinical trials, to have, exploding pill jars to remind you to take your pill, and all kinds of ways to try to keep people compliant with oral therapy. So I think that it's an ongoing issue, just like when your blood pressure gets better, if you stop taking your blood pressure pills, it's not going to be okay. I think here too, we have a very different group now. We have choices for TKIs, and I think all of you would agree that it's incredibly important to focus on the side effect profile in terms of maintaining compliance. That said, Jorge, would you agree that in the first month of therapy, pretty much anything you start has a get used to it time, right? So whichever one of the TKIs in those first 4 weeks, people are likely to be experiencing something. So do you tend to try to get them to hang in there at least for that first 4 to 6 weeks? Or do you find that if somebody's having a bad side effect, you're willing to switch them even at that early time point?
Oh, absolutely. I think Manella mentioned something very important. I think the education, the information that we provide to the patients, and let them know that there's that, getting used to the drug, and with some adverse events that typically we see more frequently early on. We unfortunately see these itch to very rapidly change patients from one drug to another and to another, not only is that detrimental in terms of just going through all your options for no good reason, but also what are you trading? There are these early adverse events that may be transient and they're not life-threatening, and you may be trading for other drugs that may have a higher risk of adverse events that are silent, but they may occur later. I mean, are you going to give them more of a risk of an arterial-occlusive event or a pleural effusion that may happen later on? And those are more significant. So I think we need to be very cautious in what really means intolerance and what really is an indication to change. But again, helping our patients between education and helping them navigate through this early period is critical.
I think that if you see what happened here, it's kind of exhibit A of what the problem is with running away from therapy. So this patient developed abdominal pain in June of 2020 and went to the ER, where he had a massive white count of 425,000, low hemoglobin, platelets were still okay, but he had massive splenomegaly. And the bone marrow biopsy actually didn't show transformation to acute phase. He had chronic phase disease. He still had a 922, and he had no mutations and was started on Hydrea and dasatinib to calm things down. And the CBC was normal in 5 weeks, and the spleen was not palpable, and things were puttering along. And now he gets a 3-month RT-PCR of 2%. So this patient, tried the imatinib, but he didn't really fail imatinib. He just dumped it. And now this is the situation. So Jorge, at 2% at 3 months, what are you doing?
Keep going. I mean, the patient's doing well. That's a good response, and you continue and check again 3 months later.
Exactly. And I think that, Ellen, it was a great case to pick, because I think that so people are jumpy when you have somebody who presents in this fulminant manner, and they'll say, oh, but he failed imatinib and now he's not automatically negative, we should switch again. And I think here, just getting back to the point that you've made several times, you want to try to keep people on the straight and narrow if you can, and not be jumping from therapy to therapy, because you'll be 3 drugs in a period of a month, and then where do you go? So I think that that would be a good way to kind of end this portion, to say that this patient is now doing okay. Let's hope we keep him on his med and don't switch to a different TK.